Tonight, it's question time with our difference. We are spending the whole hour trying to find solutions to the enormous challenges facing the NHS. And no matter what nation you are in, what stripe of government, the problems are largely the same. And to discuss them, we are in Hoddesdon in Hertfordshire, just north of London, which is one of the safest Tory seats anywhere. We have an expert panel and an audience eager to debate some ideas. Welcome to Question Time. From the government, Will Quince, who's a Minister for Health and Social Care. The Colchester MP has been in his current post for a matter of months. A few years ago, as perhaps a great example of preventive health, he lost 6.5 stone in just 8 months. Congratulations. Wes Streeting is the Shadow Health Secretary. He says the NHS is broken and Labour will commit to the biggest expansion of recruitment in NHS history if they win power. But he got into a recent spat with doctors after saying GP services must reform and improve. Dame Clare Gerada has been a GP for over 30 years and is now President of the Royal College of GPs and co-chair of the committee looking at the NHS's future. She's advised the government on the mental health of NHS staff and chairs a charity aiming to reduce suicide among healthcare professionals. The crossbench peer, Lord Victor Adebowale, is the chair of the NHS Confederation, the membership body for all NHS organisations, often seen as the voice of NHS leadership. He was one of the first so-called people's peers appointed to the Lords over 20 years ago. And the author and journalist James Bartholomew has observed healthcare systems across the world. He says despite being fondly regarded since its inception in 1948, the NHS performs poorly in comparison and needs radical reform. To our panel, to our audience here in Hoddesdon and, of course, to you at home. Well, we are all aware of the intense problems facing the NHS. Many, though not the government, are calling it a crisis. So what is going wrong? I'm not going to give an exhaustive list, but just to get a bit of context, record numbers are on waiting lists, waiting longer for ambulances, and huge numbers are stuck in hospital waiting to leave to get social care. There are problems with staff vacancies, but we do have more doctors and nurses than before the pandemic, but they are treating fewer patients and excess deaths are worryingly high. Our outcomes can be poor. We have the worst cancer death rates in the G7, for example. We have fewer GPs and of course, there's a small matter of strikes in the NHS. We are going to look for solutions tonight. We've talked about the problems for many weeks now. We're looking for solutions, and we're looking in 5 different areas. So the structure and funding of the NHS overall, hospital care, GP care, social care, and, of course, mental health care as well. So that's how we're going to do the programme. Join the conversation on home, on social media in the usual way, and let's hear what you've got to say as well. Let's take our first question from Ruby. Ruby Adesuyim.
Well, is a completely free NHS based on its original goals still a realistic option?
Is a completely free NHS still a realistic option? Wes?
I think it has to be. When I had kidney cancer last year, the one thing I didn't have to worry about was the bill. And I think it's that central founding equitable principle of the NHS, a publicly funded public service, free at the point of use, that has made the NHS a loved institution for 75 years. And it's in defence of those principles that we need to reform the NHS to make it fit for the 21st century. Because Fiona's given us the diagnosis of what's wrong. It's not the model of funding that's wrong, it's how we spend that money and how we deliver care. If you compare the NHS to other countries that have better outcomes, we're basically top of the table almost when it comes to spending in hospitals, but we're either at the bottom, near the bottom, or seriously lagging behind in primary care, general practice, in social care, in mental health and community services, which means we do late diagnosis, which means less effective and more expensive treatment. And one of the tragedies of where the NHS finds itself today is that if people can't get a GP appointment, which costs on average £40 for an appointment, they end up turning up at A&E, which is overstretched and costs as much as £360 on average per appointment. So we're in the worst of all worlds at the moment. where we've got a broken health system that's costing us lots of money and delivering poor outcomes. And I want to see the focus of healthcare shifted from the hospital into the community, better access to primary care and general practice, more front doors into the NHS so people can get seen and diagnosed and treated faster, better use of our amazing life sciences and technology in this country because, you know, for all of the challenges that we have today, one of the reasons why I'm optimistic is this country has some of the best life sciences and technology in the world on our doorstep, and we need to deploy it faster so that the NHS is once again the envy of the world.
Well, there's not much there that actually Wes and I would disagree on. I mean, since its formation in 1948, the NHS has been there for our population. And, you know, when I look at some of the best and worst experiences in my life, they've been in the NHS. It's always been there for my family, and I want to ensure, and my mission as a health minister is to ensure that it is always there, free at the point of use, for everybody in this country. I want every family to have that security and confidence to know that if they need healthcare, the NHS will be there for them. Now, Wes set out some of the challenges that we do face at the moment, and the system is under considerable pressure, and that's despite record investment, as you rightly pointed out, Fiona, and record numbers of staff.
Let's just look at... Hang on a second. I'll let you come, but since we're talking about investment, let's just look at a graph looking at funding of the NHS. This will be familiar to you in terms of where funding was for the NHS before the Conservative government came into power and where it is now. So as you can see, if you look at the average there, it's pretty dramatic in terms of the drop in funding. So when you talk about record investment...
Yeah, so we're spending more on...
That doesn't look so good.
So we're spending more on health and social care now than ever in our country's history. It's real terms growth every year. So if you take 2000...
But that's naturally going to happen because of inflation.
If you take two... Well,
but
okay,
as a percentage of an increase, the average increase has been something like 3%. But when you look at that, it's more like 1.6%.
But even in real terms, if you take, for example, 2010, it was around £100 billion that we spent on the NHS. By 2025, it'll be £166 billion. And actually, if you look at when the times were tough, for example, when we came out of the economic crisis in 2008, 2009, the coalition government actually, despite having to make reductions in spending elsewhere, prioritised the NHS.
OK, so we're talking about solutions.
And we're doing exactly the same now, Fiona, with an extra £14 billion
So in terms of funding, no change there. Structurally, anything that you would change?
So, there are lots of things, and the NHS will always need to be reformed. But what I don't propose, and I don't think is sensible, is some of the large structural reform like Wes is proposing, that would not just be hugely expensive, but would also be hugely disruptive. But where Wes is right, actually, it's our life sciences, genomics, gene cell therapy, and some of the really exciting transformational work. One of the key things we've got to do is ensure there's huge variation across our NHS. In some parts of the country, trusts perform incredibly well. In other parts of the country, they don't. So tackling that variation and empowering local communities to have join up at a local level is really key.
All right, let's get some ideas and some reaction from our audience. The man there in the glasses.
So we talk a lot about the funding that goes in, but I don't often hear the conversation about cutting back in terms of getting rid of the archaic processes or trying to reduce the public misuse of the NHS. It's no good keep throwing money in if we're not going to address the problems that need to cut costs in the first place.
All right, and let's hear from the man here in the front in the blue sweater.
Yeah, thank you. Wes, you talk about the importance of primary care. Well, one of the issues with primary care, I find, is actually getting to see a doctor face-to-face. What would you suggest could be done to address that?
Well, I tell you what, we are going to come on and talk about... Are you talking about GPs?
Yeah.
We're going to talk about GPs a little bit further down the programme, so will you forgive me if we come back to that?
Yes, of course.
Let me just hear from the woman at the very back in the colourful top.
I think we should focus more on prevention. We've shown that we can be really good at that through the recent eradication of hepatitis C in this country. I think we should focus a lot more on health promotion and prevention of disease.
All right.
Yeah, completely agree.
James?
Yeah, well, I mean, I think that Wes, in a way, changed the debate on this when he wrote and said, and Keir Starmer repeated, that the NHS is a service, not a shrine. And
he also said reform or die.
Yes, reform or die, yes. So I think the answers from the two politicians have been political answers, and they've not addressed the seriousness of the situation. We have 1.5 hour waits for an ambulance for someone with a stroke. I mean, this is really an extreme crisis that the NHS is going through. But it's not the first crisis. This is every winter there's a crisis in the NHS. It's an annual thing. Even 20 years ago, I was writing articles about the winter crisis, and it goes on year after year.
So what do you think the solutions could be?
Well, I have a German friend who looked through the German press over the past years to look for references to the winter crisis in the German healthcare. And he went back year by year, and he found one in 1945. And that is the difference that we're talking about. We're talking about a major difference in the success of medical services around Europe. And I believe that our service has, over many years, over decades, gradually deteriorated, and to reach this extreme crisis now. But now we're in a situation where people with cancer, if you lived in the Netherlands, there were 9,000 people extra would live who have cancer in the UK.
So tell us what they're doing differently, James, because the thing is, we know there are problems. What do you think the answers are? What are they doing differently?
I think that we should be looking at European healthcare systems to think, should we be adopting those systems? And I think if we believe
and
that
should we just explain what they are, by which you mean a combination of taxation as well as private insurance?
No, I'm talking about social insurance, whereby there's a dedicated part of your income, in income tax, which goes to your insurance, which is either with the government or with the private sector. It varies a lot country by country. But the result of having insurance is that you can go to any doctor, you can go to any hospital, and it'll be paid for. So it's universal in the continent, just as it is here. Rich and poor get treated. The difference is in the number of operations, the number of beds, the number of doctors. France has 2 times as many hospital beds as we do. Is it a surprise that they have better outcomes than we do?
Claire, what do you think?
James is not entirely correct there. Germany is going through exactly the same problems as we're going through at the moment. And also, I've just looked at the Commonwealth Fund, which is looking at all the similar health systems, and the Germans are number 5 overall ranking, and we're number 4. We used to be number 1.
In terms of what?
In terms of, well, it's not simply...
Not in terms of outcomes. The Commonwealth Fund does not deal just with outcomes. Only 20% of its results are to do with outcomes.
You can't measure...
Which Britain comes last.
You have to measure on equity. It's fine having really, really good outcomes if actually very few people can have those good outcomes. The other thing it is true. The other thing I'd like to point out, the lady here asked about whether it's free at the point of use, despite your ability to pay. Absolutely, 100%. And what James doesn't mention with the social insurance model, it's predicated on very good relationships between government, trade unions and employers. Well, what don't we have very good relationships with at this present time? So actually, the social insurance...
But that may be because of our system.
It may be, but it may also be how different health systems are formed, where they started. The NHS started after, as you all know, the Second World War and the social solidarity that produced. So if you want to disrupt for 10, 15, 20 years, then start to disrupt the way we fund our NHS, and it truly will be in crisis. And by the way, before I finish, I will take issue with Wes. I don't think the NHS is broken. I think it's under great stress. I think it's really in a difficult place. But I take issue by the work that I do every single day, and my colleagues do it every single day, to say that I'm working in a broken system. It isn't.
Victor. So the question is a completely free NHS still a realistic option? And if not, if it is, how do we make it better? And if it's not, what else should we be doing?
OK, so first of all, it's not completely free. You're all paying for it, just to be clear. You pay for it. It's not free. And it's not free. So that's the first thing. The second thing, you know, the NHS is in a crisis right now, right? But the idea isn't. And you need to think about what happens in countries where they don't have the NHS, right? And you talk to people, as I have done, who can remember health and social care, before the NHS. It wasn't good. And right now, I was in hospital the other day. If I went to the nurses who were looking after people in corridors and said, you know what we need now is reform, right? It'd be about as popular as a cup of cold sick. So this is what we need to do. This is what we need to do. The first thing we need to do is to acknowledge that we are in a crisis right now. People are on strike. Government needs to get around the table. You need to sort it out. You need to sit around the table and talk about pay. Firstly. Secondly, we've been saying this for a long time. Members have been saying this for a long time. We need a proper workforce plan, by which we need a long-term plan. So we know how many nurses we need now, how many nurses we're going to need in the future, what we're going to need to do, what they're going to need to be paid. And thirdly, we need to stick with the reforms that we've just had. Remember, in July, right, we passed, and there was general cross-party support for this, a bill that created integrated care systems, population health. They've just got started. We need to start creating healthy communities, so we need hospitals less, and my members would love that. And we need to start spending. So when you say we're spending more than ever, I was thinking, of course we are. They're absolutely great. We're not spending enough. That's the problem. We're not spending enough to meet the demand. And it varies. The thing that, I'll just say this and I'll shut up. The thing that really worries me, if you're in the poorest parts of London, your active life expectancy, right, is around 55. In the richest parts, it's 60. Now, that is not well over 60. That is not only immoral, it's expensive. And that's why we have the NHS, right? That's why you pay for it. It's not free. It's not free.
Right. Let's talk about hospitals specifically. Before we do, I just need to tell our audience at home that next week normal question time service is resumed. We'll be talking about whatever the issues of the week there are that week. We'll be in Scunthorpe, in the North Lincolnshire town of Scunthorpe, and the week after that we are in Glasgow. So if you'd like to come to either show, go to the Question Time website, you can follow the instructions there and come and be part of the debate. It won't all be about the NHS, but it is tonight. Right, let's hear from Barbara Young. Barbara, where are you?
I'm in my early 20s with a first-class nursing degree, applying for a work visa for either Canada or Australia. What would you say to convince me that I should stay and work for the NHS?
Well, Barbara, it'd be nice being in your early 20s, obviously. That's
I had my time again.
Yeah, you'd have your time, right. Well, that's an excellent question. Will, we know that retention among nurses, doctors, is a problem.
Dire.
It's dire.
It's dire. I know my daughter trained as a nurse, and most of her cohort went either abroad. They haven't stayed in the NHS because they're sick and tired of the pressures of the agency staff that don't turn up and just being dumped on all the time. And nobody ever talks about the morale of the staff in the NHS very much. But that is a major issue. They go into nursing not for the fancy salary. Yeah. They want to make a difference, and they can't because they don't have enough staff. I hear time and time again, there's 50,000 nursing vacancies. This has been going on for years, and successive governments have kicked the can down the road every time because it's costly. And we have to decide, do we want an NHS or don't we? Because that's what it's coming to.
Well, Will, no doubt you will test that there are more doctors and more nurses than there were since before the pandemic, but nonetheless, the UK has fewer doctors and fewer nurses, we're talking about here, and fewer hospital beds per person than the EU kind of top 14 average. So what would you say? And I'm sure we've got nurses. Have we got nurses in the audience here? Right. What are you going to say to them to make them want to continue working in the NHS?
I'm sorry.
Let him answer. Then I'll come back to you.
But Barbara, I mean, firstly, it breaks my heart to hear that because what I've heard
from politicians, and they talk about 15,000 new nursing places. Do you know what the dropout rate is? You see, politicians only give you figures they want you to know. They don't give you the facts.
All right. So, Will, you're sad to hear it. What are the solutions?
Barbara, it does break my heart to hear it, because retention is as important as recruitment, and we've got to ensure that we keep the best nurses and all. In fact,
so how are you going to do it, Will? That's the thing.
So we're going to do it in two ways. And actually, I know you don't want to necessarily hear statistics, but we do have over 10,500 more nurses compared to last year.
Yes, but as I've just said, we have fewer doctors and fewer nurses than EU14
We've got 72,000 in training, but retention is key.
Vacancies.
And look, I want the NHS to be the best place to work in the world. So I regularly meet with unions and others, and I know it's not just about salary.
What,
I know
talk
salary.
about
pay? For next year, yes, of course we have. But I know salary is important, but working conditions, working environments are too. And I'll continue those conversations. But you rightly picked up on workforce.
What are you going to do?
We've commissioned NHS England to undertake and publish a long-term NHS workforce plan, which Victor pointed to, setting out 5, 10, 15 years. Well, I said we've got 72,000 nurses in training, but as Victor said, we've got to look to the future. And that workforce plan that the Chancellor set out is going to be independently verified, so we can plan for the future and make sure staff working in the NHS, like your daughter, do get that support and have the workforce and work numbers that they need.
OK, so Victor, what Barbara is talking about is not only staff numbers, but also the conditions that staff are working in, and how tough they're finding that. So what are the answers?
My mum was a nurse. I'm the son of a nurse. I like nurses. They're cool, and they are. And I mean, honestly. So this is the thing, right?
So what needs to happen?
I'm about to say.
Excellent.
Hang on. Will says that he's listening to you.
I am.
What you're saying is there's no evidence that you've been heard.
Yeah.
That's the problem. And we need to do the following things. First of all, we need to make nursing actually pay. We need to make nursing pay. I personally think it's unacceptable that nurses are going to food banks. Secondly, we need to make the training affordable. And we need to make it so that we need nurses, they are fundamental. And, we have too many of them going abroad, having trained here. That's a loss to us, right? So we need to make it attractive, we need to keep them. But I think the third thing we really need to do, and it sounds... I'd much rather sit down with you and your colleagues and co-create the reasons, listen to you. How do we get you to stay? Because I know it's not just about the money. There's this notion of moral harm. So when I visit hospitals, what nurses say to me is, look, what's doing me at the moment is the fact that I can't deliver the care that I was trained to deliver, that I feel passionately it should be delivered, and I'm not being allowed to deliver it. So what we need to do is give nurses more control over how they manage and how they deliver that care, and then they'll stay. That's what's needed. And we could start doing that now, right now, and they would stay. You'd stay.
All right, let's hear from some of our... Actually, where are some of the nurses in the audience? Let's... hang on, I'm sorry. Yes, in the white top here.
Yeah, so I've been a psychiatric nurse for about 6 years. I was working as a substantive staff member for about 3. And I actually left private services to go and start locuming just because I wasn't able to afford my rent. I wasn't able to actually survive at all.
So what is it? Is it a question of purely money for you, or are there other things that would improve, that would make you happy with your...
No, not at all. I mean, it was the lack of resources that we had. It was managing unsafe patients. We weren't able to keep people safe because we didn't have enough money. I've actually now been working in the community for about 3 years, and I've been working as a locum staff member. And that has got slightly better, I would say, just because staff know that they need to be able to try and retain us. So that because I've been a locum staff member, they've almost tried to keep me because they know as soon as I leave that they're going to have somebody else who they're going to need to pay more. And in those locum posts, they've actually asked me to come back as a permanent staff member for a lot less pay. And don't get me wrong, it's not just pay at all, but it's the fact that you have to wake up in the morning and go out there and try and save people's lives for the fact that you have nothing to do it with. We have so little resources.
No. Let me just hear a bit more from the audience, Victor, if that's all right. Yes, the man here in the blue top, in the dark blue top, just the corner there.
I was just going to, first of all, say about what the gentleman on the end was saying. I'm actually a medical student in East London, so I see quite a lot of what you're talking about. And I know it'll be a bit later in the programme, but the social care aspect of that is inextricably linked. Like, it is a huge thing.
It is.
And breaking through to communities and teaching health education is really important.
Yes.
Will, I wanted to ask you, you know, I'll be a doctor in about a year, and I'm a bit nervous, if I'm honest with you, about my future. And like we were talking about retention, morale, I'm sure you probably did the same in your career. You looked at people a bit older and you, like mentors, people you look up to. I look at consultants, I look at registrars, and they look miserable. Like they don't look like they're enjoying their job. They look like they're really struggling. They look like the workload is too much. A lot of them want to leave. What can you say about, you know, because you often commit, I think, to short-term things that sound great on television, but long-term reform, long-term change, and I understand about the idea of reform. I understand what you're saying, because the NHS isn't broken, like you're saying, but what can you tell me? Because, you know, there's a long future ahead, and I'm trying to think, to be honest with you, about if I should stay or if I shouldn't.
Well, I mean, firstly, thank you very much for considering medicine, and I hope you do stick in the NHS, and because I know you will have a fantastic career. It is a fantastic place to work. I think many...
He thinks everyone looks his consultants look miserable. So what can you say to him to make him... It's not just saying it. What can you say that will encourage him?
I meet lots of consultants, and they aren't miserable. They're hugely fulfilled and satisfied in their job. But the NHS is under huge pressure at the moment, in particular because of winter. But it is an incredible job. It's hugely rewarding. And look, I've only been in this particular role since the middle of November. I've met with unions, I've met with clinicians, I've met with those who work throughout the NHS. I'm genuinely listening. I want the NHS to be one of the best places in the world to work. So yes, we're talking to consultants. I need to speak to some medical students.
To GPs,
I do speak to GPs,
because
yeah, and I know the pressure GPs.
Well, no, because everyone
too.
always assumes. So the answer I would give you, by the way, is you'll have a wonderful career as long as you become a GP.
Special pleading there.
But what I would also say, in all seriousness, is till very recently I ran a service for doctors and dentists and now nurses with mental illness. And I know statistics sometimes get bandied about. Let me just give you one. In the first year of operation, which was 2008, we had about 200 doctors predominantly come for help, mentally ill doctors. We're now getting nearly 200 per week. So something is going wrong. And the answer to your question is, in particular around junior doctors, and probably the same around nurse, a junior doctor can't plan whether they're going to be off duty on their wedding day. And on the whole, you plan your wedding, 12 months? My son planned it 15 years ahead. But you know what I mean? You plan it well ahead. And you cannot guarantee getting that day off. Now, if that's how we're treating our staff, it is appalling. Now, things can be done, and we do need a long-term plan, but I think the first thing we have to do is basically to attend to those, to be kind and compassionate to those who are kind and compassionate to us when we're sick. And if we don't do that, I'm afraid we're going to get more and more attrition, and stop treating nurses like naughty school children, but actually like the fabulous profession that you are, that cared for us during COVID and went way over what you needed to do and risked yourselves, your mental health, your physical health for us. So thank you very much.
James. And obviously Barbara's question is about nurses, but it gives us an opportunity to talk about hospitals in general in terms of how they're working and what could be working better.
Well, I think the question is very relevant, because it's, if you haven't got good working conditions and you haven't got happy working conditions, then you're going to want to go to Australia. And you might actually think, why Australia? Perhaps because the hospitals and the medical system there is better and you get better conditions. I'd say that in almost any... I've heard the bad morale in the NHS for many years, for decades. And you know, it's very bad that there should be that. We want a medical system where the staff are happy, because if they're not happy, they leave, and you leave the most experienced staff. And if you go on with a system which perennially, year after year, decade after decade, makes its own staff unhappy, you're dealing with a system which needs to be changed.
Wes, is there anything you would change about the hospital system?
I'll talk about that, but just on this issue of nursing and staffing and retention, because you mentioned we've got the plan for the biggest expansion of the NHS in history, funded by abolishing the non-dom tax status, but it'd be like pouring money into a leaky bucket unless we also deal with the issue of retention. I get that loud and clear. We spend about £3 billion a year on agency costs. Why are people going to agencies and locums? Because we don't pay enough in terms of people's salaried jobs. We've got to deal with that problem. Why is it?
Where would you find the money to pay them all, Wes?
Well, look,
Labour talks very carefully about how everything is costed.
Yeah, and it certainly will be in terms of our manifesto. I'm not expecting Will to sit on the panel tonight and pluck a figure out of thin air as to where the government will settle, but they have to look at the costs of what happens if you don't act. How much more the NHS will pay in agency costs unless you pay your staff well. Why people will leave if you don't invest in things like hot food overnight when people are working nights. Just those little things that make people feel valued in the workplace and able to do their jobs well. That's what's wrong. And, you know, I'm not trying to make people more miserable when I say that the NHS is in crisis or the NHS is broken. It's certainly not the fault of people working in it. But look around at the state of the service and what we've just heard described about the morale of the people who work in it, about how long patients are waiting, about how many patients are waiting to be discharged from hospital because social care isn't working either. The front door to the NHS is broken. In primary care, it's overwhelmed. The exit door from the hospital is broken and blocked because social care is underinvested in. And our hospitals are clogged up with a breakdown in emergency care, delays in ambulances, delays in A&E of a like we've never seen before. And when I raise these issues, and when I say the NHS needs to change or it will die, it's not for the sake of rhetoric, it's certainly not to make people feel miserable, but it's because our NHS is in jeopardy. And going back to the very first question of the evening, if we want an NHS that's still publicly funded, free at the point of use for the next 75 years, we've got to face up to the scale of the crisis, we've got to ask how we're spending the money that's already in the system, and we need a serious plan for investment. Because why is it the last Labour government was able to increase NHS spending in the way that we saw on that chart? Is because we got the economy growing, because people were able to spend more in the economy, because the taxes were flowing in without having to charge people more income tax in the way that this government has. So we've got to fix the fundamentals of the economy, but we've also got to change the way that the NHS works. Otherwise, it won't be there for the next 75 years.
I need to move on.
If I don't... I'm sorry, but I've got to say this, because if I don't say it, it's not going to be said. In London, 50% of our nurses look like me, right? And they report very different treatment in our hospitals than white nurses. And some of those nurses must go and work for agencies. So there is something about how we treat people. It's not just about pay, it's about how we treat people in hospitals, how we treat people in the community. They don't have to stay in hospital, they can go and work for agencies. So there are three things that need to be fixed. Pay, how we treat people, particularly around discrimination, and flexibility, which involves listening to them and co-creating the solutions. Thank you.
All right. No, listen, thank you, Victor. Let's take another question from Susan Maskell.
Good evening. Is Labour's suggestion for the NHS to start employing GPs a workable idea?
OK, right. Wes, this is your idea, or Labour's idea. Just very briefly explain what it is and why you think it's such a good idea.
Well, it's one of many things we're looking at in terms of primary care. We need more GPs because they do a valuable job. I think we've got a big problem at the moment where 1 in 7 people can't get an appointment and 2 million people are waiting more than a month to see a GP. But there's a trend in general practice at the moment where, whereas when the NHS was founded and for much of its history, GPs have effectively run their own businesses and small practices, people coming into general practice now are opting to be salaried GPs, and by 2026 they'll be the majority. So the question we're asking, because I think we do have to face up to the challenges in the NHS and think about how it might need to change, is do we accept that the partnership model's phasing out and that we're going to have to bring in a new model of salaried GPs and make sure that works? How long do you think that would take? Well, I mean, I'm talking about you know, a 10-year plan for health and social care because we have to grip the crisis but think long term. But I would phase out GP partners over time.
What, over a generation?
Yeah. Or the
OK, so it's a
you have to,
long-term plan.
Of course it is,
Right.
because, I've seen what Will and others have said. I'm not about to come in and just nationalise the entirety of general practice and alienate a whole bunch of people who've built successful practices. I don't want to get rid of good practices. But the question for me is, either you bring in a new model of general practice to meet the trend, or where we've got GP partners saying, actually, don't throw the baby out with the bathwater, this is really valuable. Well, OK, but tell me how we need to fix it then. Because at the moment, it's withering on the vine, and that's not good for anyone. So that's one of many things that we're looking at to fix the front door to the NHS and primary care. Because if we get that right, everything else becomes so much easier, faster diagnosis, better outcomes and better value for taxpayers' money.
Claire, there was a bit of an old-fashioned look going across your face there, I have to say. So as a
I'm
GP,
worried you put us in arm's reach as well, because we disagree on this. So
as a GP and head of the Royal College of GPs, are you in agreement?
Well, the first thing that's important is we've got to deliver good care for patients.
Yeah.
All right. And the second thing we have to say is that there are different models already emerging. So there's salaried doctors, there's big multi-practices, and there's GPs who are employed by acute hospitals. And there's also what I am, which is a GP partner. And I've been a partner now for nearly 34 years in the same practice, with the same community, almost with the same patients. And it's been very stable. The problem we've got isn't the model, it's actually what we're expected to do. We are now doing more and more of out-of-hospital work. We're inundated with work. And unfortunately, as a partner, you're the last man or last woman standing. So you do your day's work. You're the last one to switch the lights off when you leave. You'll log on at home after not me, but after my colleagues put their children to bed, and you log on first thing in the morning before you go to work. So the actual job that we're doing, rather like the lady who talked about nursing, is unsustainable. And that's the problem, Wes, not the model, but it's the unsustainability.
What would you need to do to
Claire,
fix
can
it?
I just want to show a graph, because if you're saying at the moment that GPs are inundated and cannot cope, let's just look at a graph which shows, compared, again, I'm just comparing it this is from the OECD. When you look at OECD countries, when you look at where the UK is in terms of treating people in hospitals, we're right at the top. Yeah. But when it comes to the kind of care that you're offering, we're right at the bottom. Yeah, so we're treating far more people in hospital and far fewer people when it comes to primary care. Well, but you're saying that you're inundated. Well, I'm just looking at the graph.
Today,
I mean, the graph is there.
Sure, I can't understand that graph. Maybe.
Well, it's a reputable graph from the OECD, but you're saying you're doing too much already.
Right, today, 1.3 million people were seen in general practice. Yeah. That is 5 times the amount that was seen in outpatients and 15 times the amount that was seen in accident emergency. Yet you would think that we had a national hospital service. General practice is rarely mentioned. It's often forgotten. Yes. So the myth is that we're not working. When I started in general practice, 90% of all patients with diabetes were looked after exclusively in hospital. Now 90% is looked after by me, and that goes for the same for heart failure, for respiratory disease, for depression. With that work hasn't come the simultaneous shift of resources. No. Now, Wes has asked what we'll do. I'm very happy to send you a list of what you should do. You should look at the incentives for continuity of care. I'm sure all of you...
We've committed to that.
...want to see the same doctor or the same nurse in order to deliver you proper continuity. Yet we have a fixation, not a fixation, but we have a focus on access, only access. 45% of patients seen today were seen on the day they asked or the next day. OK, so we are seeing patients. That's number one. You've got to sort out the locum issue. You've got to sort out why it is better for that young nurse to work as a locum rather than to work in a substantive way, which I suspect would give you much more stability in your life. So there are things you can do, but please, please don't throw out the jewel in the NHS crown, which delivers innovation, continuity, flexibility, and enormous value for money.
Yeah. OK. The woman in the front in them.
Hi, so my name's Ezgi. I'm a GP trainee, so I'm a junior doctor. And I just wanted to touch on pay, because I almost don't want to get paid more, because I know that will put me on a higher tax bracket and most of that will be taken away from me. And so what I'm left with is probably going to be roughly the same. So I actually want to be taxed less so that I get more out of the salary that I am given. I go back from my maternity leave and I have to put 2 children into childcare, going back less than full time with my salary. Majority of my funds is going to go into childcare, and I'll just be going to work just for progression reasons. And when I complete my training, I've got 1 year's worth of training left. I won't be doing GP full-time because the workload is so big that I have to prioritise my mental well-being, and for that reason I'll be doing GP as less than full-time. So I think pay is a massive factor, both as recruitment and retention, childcare, just everything intertwined.
Thank you for becoming a GP, and you'll have a wonderful time. And actually, I'm not saying partnership model is the only model. Of course it isn't. And vast numbers, a lot of our profession are women who want much more flexible working. But actually to then say we will only have an entirely salaried model, I think is not the way forward.
So Victor, what are the answers here? I mean, just looking at that graph again, I found that really puzzling, that the spending on hospitals is so much higher relative to other countries than on primary care.
It should be the other way around.
But on the other hand, you've got Claire saying, and I absolutely believe you, and you're saying, inundated with...
Oh, there's no question.
So what's the answer here?
Well, the answer is to spend more on primary care. And there's a difference between GP and primary care. So GP is within primary care and primary care. Primary care is the front door to the NHS. They are overwhelmed. They are working incredibly hard. Remember, these are the people that jabbed us, that organised the vaccines, with the flu vaccines. These are the people that you ring first, right? Who are you going to call? So there's a number of things that we need to do. First of all, we need to accept that primary care is reforming. You know, the GPs and are working together to form primary care networks, pulling together resources to try and understand what's happening in populations in order that can prevent people needing to go to hospitals in the first place.
So you say they need to be doing more of that?
They need to be doing more of that, and we need to let them carry on. So the last thing we need is a reform which stops what's already happening from happening and reaching its end. I think there is a question around the numbers of GPs. Yeah. The Conservative government has promised 6,000. I haven't seen them, and we need to be... There is a problem about numbers.
So the UK has 0.8 GPs per 1,000. The EU average is 1.2, so that's 50% more.
Well, there's a problem around the numbers of GPs, and we need to increase the numbers of GPs, and that would help. That would certainly help with the workload. And we need to improve primary care, which we are doing through the primary care networks that have already been established and are starting to do the work. We need to make GPs, I think GPs I'm with Claire. I think it's a fantastic career choice. You know, people respect what you do. You understand your communities. You're the sort of Swiss knife and front door of the NHS. But we need to respect you too. It should be worth your while to work. It goes back to the earlier question. We need to make it flexible and appropriate for you to do that. There is a trend, and this is where Wes is right, and we need to respect that trend and understand it before we change it for less partner working in GPs. We need to respect that too. But this is fixable.
I need to bring two more members of the panel, and I also need to move on because we still want to talk about social care and mental health. So I'll ask you reasonably brief if you would. James.
I mean, the statistic you gave is stunning, is it not? That the average in Europe is 50% more GPs. I mean, the access to GPs, despite what Claire says, is terrible. We have people, I know people who cannot get an appointment. You have to ring up at 8 o'clock, and if you ring up at past, you can't get an appointment. This is an intolerable situation, and it has a knock-on effect. We come on to accident and emergency, but I was told by a GP yesterday that she works in both as a GP and as a GP in accident and emergency. She says in accident and emergency, 80% of the people she sees would not have needed to be there if they'd seen a GP previously.
Right. So is the answer coming back to your idea of changing the funding model? Is that what you think it is?
Yes, I mean, basically we don't get enough bang for our buck in the NHS system. We don't get enough healthcare for our buck. They get 50% more in Europe, and they don't spend much more money.
But it's because we're spending it in the wrong...
It's absolutely vital
it's because we're spending it in the wrong place.
Don't remain closed-minded to the idea that we have to stay with this model.
But it's not about how we raise the money, it's about where we spend it.
Which gives us more healthcare.
Will?
So
I mean, when you hear statistics like that, which of course you will be familiar with, it implies that there's something not quite working.
So I'm with Claire on this, and I think the last thing general practice needs is a top-down reorganisation. I think general practice is the jewel in the crown. I'm really pleased that you're going into general practice. Not only is it hugely rewarding...
She's having doubts, actually. So I mean, what do you... you know, you're wondering if it's actually worth your while.
Stay, because it's a fantastic career, and they are at the heart of their community. And actually, what we wouldn't want to do is lose that expertise. And my worry is if we went ahead...
How do you keep her?
Well, we've got to ensure that general practice is more attractive.
And how are you going to do that?
Well, there are numerous ways in which you can do that. The first is to take some of the pressure and workload off general practice. So that can be through things like diverting more to other NHS services, so pharmacy, for example. That's one of the ways we're looking at doing it. So, for example, in Scotland, pharmacists can prescribe antibiotics. They can't do that in England. That's one way that we're looking at. But it's not also just about GPs. GPs are hubs in their community. So, yes, we have struggled in terms of attracting people to become GPs. We've got 4,000 in training, and we do have 2,300 more than we did in 2019. But what we did is then create additional roles within general practice, which have made a big difference. So it could be physiotherapists, it could be mental health support, it could be a pharmacist, for example. That is making a big difference. As Clare rightly says, there are around 1.3 million appointments in general practice every single day. That's 80,000 a day more than during the pandemic.
But that doesn't make a difference if you're on hold at 8 o'clock in the morning and then told you'll get a call sometime between 9 and 5. Never mind whether you're at work and can answer the phone. If you don't answer the phone, your appointment's cancelled and you're told to ring again tomorrow morning.
Why.
This is after 13 years, Will. And it's in its worst possible state. And I don't blame... I know there aren't enough GPs and I know they're overworked and I'm not bashing GPs. But come on, look at the state of the system. It's not a system that works for patients. And I understand why the reform word terrifies people in the professions, because we had, Will, a massive top-down reorganisation which squandered billions, an organisation so big you see it from space under Andrew Lansley. I'm not talking about a top-down reorganisation. I'm talking about a system that works for patients, a system that responds to patients and doesn't keep them on hold at 8 o'clock in the morning. That's what I want to see.
In moving on, or we won't deal with two massively important issues, which are social care and mental health. And just since you mentioned Scotland, well, obviously we're in England. We're talking mainly about the NHS in England. Of course, some of the things we're talking about affect the NHS throughout all nations. We will be going to Scotland and to Wales in the coming weeks. Of course, we'll talk more about those issues there. Right, let's move on to social care, because we are talking a lot about that on Question Time over the weeks. And let's take a question now from Lynn Gunn.
To solve the social care crisis long term, is it not time for social care to come under the umbrella of the NHS?
Right. Now, it's a very important topic. We could talk about it for a long time. We have to be reasonably brief, I'm afraid. Victor, is it time for social care to come under the umbrella of the NHS? Because, of course, social care is run in part by local authorities, but in large part also by thousands of private providers.
So, I was in Newcastle the other day, and in Newcastle, the NHS and local government work really well together in delivering, understanding what people need, so you don't get pulled from pillar to post. You go one place, you get a joined up care. The problem with social care, and I've run social care organisations, is for years we haven't fixed social care, right? And unless we do, it creates the backlog in the hospitals, it creates the demand on primary care, and one of the problems is this: we don't pay enough, right? And social care workers can walk out of... It's just, we asked, the Confederation put evidence and papers to the government saying we need to pay about £10.50 an hour for social care workers.
So, Victor,
to make it attractive for them. And we need to give them a proper career structure.
OK, but just coming back to...
we would actually reduce the hospital...
We would. I'm sure we would.
In Newcastle, you get 50 extra beds.
Given that... Because this is the one thing I've tried to find the answer for and I haven't managed to. When it comes to the NHS, obviously it's up to the government or peer review bodies, depending on your point of view, as to what staff are going to get paid. When it comes to social care, in large part, it's down to private providers. So how do you make them pay their staff more?
Well, local authorities can actually say to there's not just private providers, by the way.
No, I know they're not, but there are a lot of
when you think about social care, you think about, and this is important.
OK, but just answer the question. I know there are private providers as well as some
there are private providers.
So how do you make them pay people more?
Well, I think it'll be very difficult for them to get staff if they don't pay the going rate. That's the problem.
But that's what you're doing now?
So when I run when I run social care services, it was very difficult to get people to come and work for us because they could get jobs in Tesco's that were less stressful for more money. If you increase the rate, you get people back into the social care.
So you need local authorities to increase the rate and hope that private providers would catch up.
Social, you get local authorities, you get social enterprises. 38% of social care is provided by social enterprises and not-for-profits. So they need to be paid more by local authorities. Local authorities need to be paid more by government, so we can get people back into social care. We get people back into social care, we get people out of hospital. We get people out of hospital, we don't have two people in a corridor. It's straightforward.
The answer to the question, which is should the social care come under the NHS, is I think yes. I think we need, and I'm very angry with successive governments who've kicked this issue down the path. They haven't addressed it. It's as if suddenly the fact that we're all ageing has been a real great surprise to them. And you ask why you can't see a GP, and there are problems with access to GP. I'm not saying they're not. It's because in many ways we're becoming the proxy for social care workers. We're going in to our patients' homes. We're going in to make them a cup of tea and to make sure that they're up in the morning. And I'm not a social care worker. And absolutely agree with Victor. We've got to pay social care workers more. We have to give them a career structure. Look at what happened during COVID, how badly we treated our care home workers. So I think we should, and it's for politicians to work out.
We have to be reasonably brief, because otherwise we're going to get to mental health and have no time to discuss it, which personally I think would be a really bad thing. So, James.
Yeah, I think it's an interesting point that at the moment we have a structure where the NHS is responsible for when you're ill, and then the local council is likely to take over when you're discharged from hospital if you're unable to look after yourself. And the local council is already strapped for cash. And so they are reluctant to take people on, except on a very rationed basis. You have to fill various forms and various qualifications, and then they might finally take you. So it's really difficult. This inherent conflict, which I think you've correctly identified, whereby they won't move easily to social care. And yes, so there's an argument for unification of these two things. But if you have the NHS running this, it already is a monolith of 1.5 million people. You're going to make it even bigger. The chances of it being efficient and working well, I'm afraid, are very small. In Germany, they have an insurance system where the insurance company is responsible for both the healthcare and the social care. And they have a strong incentive for you to move from one to the other. And so, because it's cheaper in social care than it is in the hospital.
All right,
so that is likely, it seems to me, to work much better.
Let me bring in Will.
Is
it time for... And I can hear you don't agree with it. You wait to keep saying, I don't know, but I've got to let the others answer, or we will not move on to the final subject, and that it would just not be right. So, Will, is it time for social care to come under the umbrella of the NHS? I presume you think no, because you haven't done it.
Yeah, so I agree with Victor, and it's a no, but actually the join-up between local authorities and the NHS has never been stronger through the creation of integrated care systems. And they are relatively new, and integrated care boards, but they are working, and that join-up is happening. We spend about £21 billion a year on adult social care, and we recognise the challenges in social care, and where Victor's absolutely right. Many of the pressures on our hospitals and urgent and emergency care are actually driven, as you rightly say, Fiona, by those 13,500 people who are medically fit to be discharged but in our hospitals. So the answer is more investment in social care. That's why we're putting up to £7.5 billion in over the next 2 years.
Wes, briefly, I'm afraid.
I don't want to merge the NHS and social care, but I would like to, over time, build a national care service where wherever you live in the country, you've got national standards, national expectations in terms of the provision of care, staffed by people who are paid well, have a good career structure, and where actually, if you can put it on par with the NHS, people can move from careers in social care into the NHS and vice versa, because they are different, but they have complementary skills, and the workforces in both the NHS and social care have a lot to offer each other. But unless we pay people better, we're not going to get the quality of care, we're not going to be able to recruit and retain the care workers we need, which means even when the government does put extra money in, as they did in September, not only is the money still not reaching the front line today, even when it does, unless the pay goes up, you are not going to get the people you need to provide people with the care they deserve. Fix that, you fix social care. Fix that, you decongest the hospitals. Fix that, we've got a chance of having an NHS and social care system that's fit for the future.
Let's take our final subject. From Steve Wright.
Inadequate mental health provision is causing an excessive strain and even greater costs to policing, family, social care and A&E. Why can't it be properly funded as suggested by the BMA?
So when you talk about it being funded by the BMA, in 2019 the government committed to spending an extra $2.3 billion per year on mental health, and even way before that David Cameron talked about mental health and physical health being treated on a par. That 2.3 lasts till 2024. The BMA, which you refer to, Steve, wants 5.2 billion. So put in more money and it might actually make it better.
Well, as you say,
well,
as you say, Fiona, we're currently spending 2.3 billion.
But Steve's question is, why are you not funding it as recommended by the BA, which is is twice that?
Well, I haven't seen that BMA figure, but as I say, we've committed to an extra £2.3 billion a year. I recognise the challenges that Steve faces. I've been in accident and emergency departments. Although they're relatively small numbers, they do take up the patients take up disproportionate amounts of time of both police and
so
NHS
is that
staff.
your answer, that the money that's committed, that's it?
Well, no, it's also about doing things differently. So, for example, we're investing an extra £150 million in capital, so mental health ambulances, mental health. I remember from my time as Children's Minister, we're investing in mental health support teams in schools. We've got 287 up and running at the moment, 500. So building resilience too. But yes, we do need to do more in this space. Parity of esteem is really important, and it is one of the big issues which we need to tackle.
We've got very few minutes left, which I'm very sorry about, but Claire, if we could...
Well, I absolutely agree. I think, of course, most of my day is spent dealing with mental health, but I'd just like to say some successes, because I think we always think of failures. We've seen an enormous change, for example, in liaison psychiatry, that's psychiatry across in hospitals. We've seen really good success with perinatal psychiatry, that's mothers and babies. We've seen increased funding in eating disorders. And we've currently got a plan, there is a plan to put a mental health worker into every school. So I think, to be fair, and we've got what's called the IAPS, so the improving access to psychological treatment, which is the envy of the world in terms of how easier it is to access counselling. So I think we've got to be fair where things are working. We can way to go, but I think there are some good examples around mental health.
OK, Victor.
Not good enough, I'm afraid. I think those things are good, and I think you're right, Claire, to raise them. But we've been waiting for a 10-year vision, 10-year plan for mental health for 10 years. It's not here, and we need it. I am really alarmed about the increase in the numbers of young people that are turning up, really damaged. And we also know that people with long-term mental health illnesses die on average 20 years before others of physical illnesses. So we have a major problem which has been ignored for too long, and my members are really reeling under the pressures of the mental health problem. So we do need to return to mental health. I think we need to... it is a funding issue, but it's also a policy focus issue. Okay. And so that's why I'm pleased that you actually brought it up, because it's the one thing that we never talk about, but it drives demand across the NHS.
Yeah. OK, Wes?
So as part of our plan to put more services into the community through things like district nursing and health visitors and more general practice, we want mental health hubs in every community and mental health support workers in every school. And to fund 8,500 extra workforce you'd need to do that, we would close a tax loophole that benefits private equity fund managers, which would enable us to do exactly that. And in doing that, not only does it mean we'll reach people before they reach crisis point, because what happens at the moment, loads of people go in with mental ill health and are told, sorry, we can't help you yet, you haven't reached crisis point. The NHS should be working the opposite way round. We should be preventing people from getting to crisis point, which is worse for them and more expensive for the taxpayer.
When they do get into crisis, they go for crisis now.
Yeah, exactly. And if we do that, we can help people with their mental health and alleviate pressure on GPs at the same time.
I'm afraid the reality is, despite whatever these politicians may promise, that mental health will always be underfunded under this taxpayer system, because there will not be the money to pay for the things that they talk about. They will just not be there. And it'll be forgotten, because it is a Cinderella service, and it will always be a Cinderella service as long as it is funded by taxpayers, because there's so many competitions for taxpayers' money. And Wes Streeting, he's spending money on everything he's talked about.
Yeah, but I've also said... hang on, James.
He's only funded one.
I've said exactly how...
No,
we
do not know the numbers.
No.
So
I said exactly where the money would come from.
Hang on, I can't hear what you're saying.
We have a double think going on here. We have a double think going on here, whereby everybody here acknowledges there's a crisis, but nobody here, except me, is willing to say we need a different system. You just go on, it's a crisis, but we go on just as we are.
Hang on, we're out of time. I sort of feel like we come back full circle because we're now talking about the structure of the NHS and back to that. I know you all want to come back in.
I was just stunned by his optimism.
I'm afraid our time is up. See, forgive me for not coming back to you because I wanted to hear about your personal experience, but I'm afraid we are out of time. So much to talk about, so little time it feels. Thank you very much to the panel for coming along this evening. Thank you. Do you think... Did we hear some answers? Some solutions? Not really. My God. Well, we tried. We tried, didn't we? We certainly tried. Thank you at home for watching. Next week, we will be in Scunthorpe. Apply if you want to be in the audience there from Question Time in Hoddesdon. Bye-bye.